everyone, and welcome to today's Public Health Ontario Rounds presentation on measles and rubella outbreaks experiences from the Netherlands. My name is Dr. Sarah Wilson. I'm the Deputy Chief of Communicable Disease Control here at Public Health Ontario, and I have the great pleasure of introducing today's distinguished speaker and moderating today's round session. Before we begin today, I'd like to take a moment to acknowledge the land on which I live and work. I am moderating today's rounds from Toronto, Ontario, on the traditional territories of many nations, including the Wendat, Anishinaabeg, Haudenosaunee, and Mississaugas of the Credit. This land is part of the Dish with One Spoon Wampum, an agreement to share the land and care for it together in peace and respect. As we gather for this talk and what I think will be a very interactive discussion today on measles and rubella, it feels fitting to reflect on how vaccination is also an act of shared responsibility, one that protects not only ourselves, but also those around us. And this idea of collective care echoes Indigenous teachings about interdependence and reciprocity. Now I'm going to move on to mention some brief housekeeping items. So to ensure an engaging and optimal experience for all, the Zoom chat has been disabled for this session, but what has not been disabled is the Q&A functionality. So you'll find this at the bottom of your window, and please do pose content-related questions for our presenter. I think we'll really have an opportunity for some really rich interactive discussion at the end of the presentation. And then finally, just noting that for anyone who might experience technical issues during the presentation, please email capacity building, all one word, so capacitybuilding@oahpp.ca. So it's now my pleasure to introduce our speaker, Dr. Susan Hahné, for today's presentation. Dr. Susan Hahné is a very experienced medical epidemiologist who's worked at the National Institute for Public Health and the Environment in the Netherlands since 2005, and there she has led the response to several measles and rubella outbreaks. Dr. Hahné has a PhD in epidemiology from Utrecht University in the Netherlands, and since 2024, she has been the editor-in-chief of the journal Epidemiology and Infection. I also want to make a brief note that we also have Dr. Christine Navarro, who's a public health physician who supports the immunization and vaccine-preventable disease team here at Public Health Ontario, available as a resource for us in the Q&A session to answer any Ontario-specific questions that may arise. So with all of those introductions and housekeeping notes covered, I now will pass the podium, so to speak, over to Dr. Susan Hahné. Thank you again, Susan, for giving this talk. We're really excited and really looking forward to it. So over to you.
So thanks a lot, Dr. Wilson, for this great start of the session and also for the introduction. And of course, for the invitation to share the experiences from the Netherlands. And as you'll see, we have close ties with Canada, and so I think it's really opportune to exchange and to learn from each other. So I don't think I have conflicts of interest, but I have co-authored a book, vaccination programs. I will mention that later. It's open access now, and I'm editor-in-chief of Epidemiology and Infection. So I'll put it all up. I trained in health science medicine. I worked in hospital for 2 years. Then I had the opportunity to do this fellowship. So that was really a start of my more international career, working for 2 years in Wales, the United Kingdom. And I stayed in the UK to specialize in public health. Then went back to the Netherlands and joined the National Institute for Public Health and the Environment in Bilthoven, where I completed a PhD. I was head of department for 7 years and then currently work in the vaccine unit. And since last year, taken up this role as editor-in-chief of Epidemiology and Infection. So in the talk, I will go quite a bit of background on the situation in the Netherlands for measles and rubella vaccination, the approaches to surveillance and monitoring, then diving into the vaccine coverage situation, focusing on the low coverage subgroups. Then the epidemiology of measles and rubella, focusing on outbreaks. Then a whole section on research. Then on interventions that we have to increase uptake. And then a summary synthesis of it all. Now, the learning objectives are to understand and identify the risks that occur when there are clustered communities of low vaccine coverage for measles and rubella. to describe the current approaches to outbreak control in the Netherlands and the current approaches to rubella prevention. And that's something specifically we are looking at the moment. Now, the Netherlands, so 18 million inhabitants, capital is Amsterdam, the government resides in The Hague. Just this year, we've celebrated 80 years of freedom after the Second World War. And I thought it good to show a picture of a Canadian tank. The Canadian Polar Bear Division was very important in, and that has been commemorated in the celebrations for 80 years end of the war. So what is very special about the Netherlands school system is that we have a freedom of education. And that means that we have state-funded schools of various denominations. So of course we have a lot of general, but also Catholic, Protestant. And then we have a few schools that are of Orthodox Protestant, Islamic and anthroposophical denomination. So these are not private schools, these are state-funded schools of that specific denomination. And that goes back to actually a constitution article. On the picture, you see the National Institute of Public Health and the Environment. So that's now in Bilthoven. It's going to move to Utrecht. We have regional public health institutes. We have a National Health Council that is responsible for advising the government. If there's a major incident, we have a National Outbreak Management Team that advises the government. And internationally, our closest bodies are the European Centre for Disease Control and WHO Euro, that is in Copenhagen, and ECDC is in Stockholm. So in terms of the vaccination program, the program started with rubella vaccination for girls only. It's in 1974, age 11, and that was actually meant to allow circulation to happen, but to specifically protect girls. Many countries started like that, I guess, with rubella vaccination. Measles vaccination started in 1976 with monovalent measles. Then our MMR program started in 1987 with 2 doses and generally or a relatively late second dose at 9 years. And that was brought forward, the second dose, in 2024. So we have the vaccine delivered in well baby clinics. And I think, one of the key assets we have in the Netherlands is a national vaccine register. So that's linked to the population register. And that's actually used for call and recall, but also, of course, to monitor how the programs are doing in terms of coverage. Now, the components of the vaccine-preventable disease surveillance are all active actually in the Netherlands. So we have sero surveillance, disease surveillance, pathogen surveillance, adverse events surveillance. That's done by a separate organization in the Netherlands. Of course, we monitor coverage and we also have a monitoring of attitudes towards vaccination. Now, all of those methods we have described in that book that we published in 2021, together with Kaatje Bollards and Paddy Farrington. And I'm very pleased to say that it's now free online. So it's through the Routledge page, but you can easily find it online. Now, if we talk about coverage, this shows the vaccine coverage of the first and second dose over time. So that's the reporting year. And we also see in red the international 95% target that we want to achieve. And the yellow line is the more general target for vaccinations that we strive for. It is obvious that we've seen a big drop, and that is happening already in COVID era and before that, but a more dramatic drop afterwards. And one of the difficulties with interpreting this decline is that we also now have informed consent needed by the parents for the vaccines to be registered in the national register. So at the moment, we can't document our vaccine coverage exactly. We have to make estimates because this informed consent has been implemented. But it will only be a small underestimate of the real coverage. So you can see that we have a very big decline. And yeah, that's a big change for the Netherlands. We used to be at a very high level. And that would make you wonder why, when we were still in this high vaccine coverage era, why we are listed in these countries at very high risk of reintroduction of polio in the European region. This is a report from 2009, but we are up there with Georgia, Tajikistan, and Uzbekistan. And the main reason for that is that we have this clustered community of the Bible Belt, where the vaccine coverage is low and where there's real clustering. So these reformed congregations were established already centuries ago. And actually with the arrival of smallpox vaccination, the refusal of vaccination started. And I've looked into it a bit more, and to me, it seems almost a coincidence that at the time when these subgroups of religious people wanted to distinguish themselves from each other, also the smallpox vaccination came up. And I think they just happened to take that as a thing to distinguish themselves from other denominations within the Christian religion. So had there been some other intervention for prevention, maybe it would have not been so specifically about vaccination, but it has been specifically about vaccination since then. And the arguments are all about predestination and divine providence. I'll go into that a bit more. Now, it's only a tiny proportion of the Dutch population, and the vaccine coverage is reasonable. But the problem is that there's real clustering. So there's geographic clustering in the Bible Belt, but they also have their own schools, state-funded Orthodox Reformed schools. And the clustering makes that there's much less benefit from herd protection. Now, as you maybe can see from the pictures also, this is not a marginalized community. This is a well-represented community, even in Dutch politics, where they have their own political party, which is represented in the Dutch parliament, and also in many municipalities, they play an important role. So this is not a marginalized community. Now, this thing about divine providence goes back to the Heidelberg Catechism. And that's a very old document. And this catechism is something that people who adhere to the religion usually have to learn by heart. So it's a lot of questions. Somebody asks a question, and then the other person has to know the answer by heart. And this question is very specific about the providence. So it means that God governs everything in our world, but also health and sickness. And that the things that happen to you do not happen by chance, but there's a meaning, there's a fatherly hand that governs all of these things. So you shouldn't interfere with this divine providence by being smarter than God and preventing diseases. So that's what's the basic thing about refusal of prevention. So there's no refusal of treatment at all in these communities. And then, the link with Canada is that many Orthodox Protestants after the war migrated to Canada. And I found this online, large number of Dutch migrants where a significant proportion were reformed. Now, that explains the link of these outbreaks between our two nations. So it started with polio, and all of the outbreaks in Orthodox Reformed, you see that in the column population, all of them have spread to Canada and some of them even to the US. So there's only one row, the measles outbreak in 2008, that was anthroposophic. So that didn't spread to Canada and also not to the US. So these clustered communities in the Netherlands have given rise to major outbreaks with major international implications. Now, this is an example for a photo from the polio outbreak where somebody is protesting in front of a church. He's a pro-vaccine protester saying, I beg you do not do this to your children. So that was a dramatic situation in the polio era. I'll come back to the Orthodox Reform, but now recently we have other low vaccine coverage subgroups. And Joyce Pijpers is a colleague who's done a PhD, and she's linked our national register to information from Statistic Netherlands. And just through a cohort analysis, she was able to assess independent associations associations and changes over time. And she found that the coverage decreased. I already showed that to you, the general coverage decreased. But now we see a faster decline in children of non-Dutch origin, also in children not attending daycare, children of larger families, and 2 other groups. And the multivariable analysis showed clearly that particularly children of Moroccan and less so Turkish origin had very pronounced declines. And that was actually a surprise to us when we finally got to get this framework to study this together. And here I show actually the picture of this determinant. We have in the publication that is recently in Eurosurveillance, all the other determinants, of course, also. But this picture is quite clear that Dutch children of Moroccan origin used to be at much higher coverage than average, but there's been a dramatic decline. And we're still actually, dealing with this in many ways. We were also able to study this at school level, where you see that the mainstream schools, the top 3, have high coverage, but the Orthodox Protestant, but also Islamic and anthroposophic schools have much lower coverage. And we were actually a bit struggling with whether and how to communicate these findings, because of course the Orthodox Protestants in the Netherlands are very well established. They are not marginalized, they are represented in parliament, in local authorities. But with Moroccan community, that's a much more recent migration. I mean, it's decades, but still the integration is less complete. And there's this risk of stigmatization with actually an adverse effect on equitable vaccine uptake. And there's this academic in the Netherlands, Klaasien Horsman, who's quite controversial, but she states that by having a narrow focus in health promotion, health protection, and being stigmatizing, we could actually have a role in the persistence of health inequalities. So that's, of course, what we want in the last place. So at RIVM, we really took time to think through systematically what are the areas of uncertainty, where are we worried about stigmatization, and how can we make sure that the rights and interests and preferences of all the stakeholders are fairly weighed in decision making. Then we did this systematic thing of a moral deliberation, and that was in a meeting that lasted about 3 hours, I think, with the predefined methods of really systematically going through. And at that meeting, the main outcomes were that the text of reports that we had already prepared were improved before made public, and that we had another stakeholder meeting. And one of the implications I took away from this whole process is that actually it would be better if we had better proxies for the risks. So it's very easy for us to talk about Bible Belt, Orthodox Reformed, people of Moroccan descent, but actually networks of unvaccinated people are more relevant and maybe a better proxy than individual characteristics. So we actually have a lot of work to do to better define who is at risk. Now then quickly over to the epidemiology. So for measles, this is the time series since 1976. So the MMR came in 1987. And you see that we've since then had mostly very large outbreaks, peaks, separated by time. And we can explain this recent epidemiology very well from our sero-epidemiological studies. These are called the Pinter studies, and that's a sampling from the Dutch population, having a large sample, 8,000 participants, with oversampling in low vaccine coverage areas. So that's the Bible Belt in blue, also in big cities, and then the national sample. So it's a 2-stage cluster sample. We have a large questionnaire in venous blood, and the samples are tested for antibodies. And because we have this Luminex technology, we can test for a whole lot of antigens and antibodies at the same time. One of the interesting things coming out of that is that we could show that the decay of maternal antibodies was much quicker in the general population than in people who had natural infection. So infants in the general population were already susceptible around age of a bit over 3 months instead of 5 months in the Bible Belt population. So that has real implications for the age of the first NMR. The other thing we could show is that based on the seroprevalence, we could see a large outbreak coming. The interesting thing is that that was accepted in May 2013, and the outbreak actually started in May 2013. So that was a large outbreak, I think a bit similar to the outbreak that has just ended, I think, in Ontario. So this was, you had more cases, but I guess you also face the thing of under-reporting. So we did a study to assess the completeness of reporting that found that it was only 9%. So the estimated number of cases is over 30,000. And this was really, as we say, a Bible Belt epidemic. So it was, the vast majority was unvaccinated, vast majority based on Orthodox religious grounds. 7% was hospitalized, and 2 fatal cases, 1 during the outbreak and 1 SSPE case, which is very unfortunate. That's arrived later. So in terms of geography, you can see that it's very clearly defined. So the regions of the coverage, that is our Bible Belt going from the southwest to the center. The measles incidence really matched that well. And actually it matches really well the proportion votes for this state reformed party in the national elections. So the Bible Belt is very well defined in the Netherlands. And at the time it spread mostly to British Columbia and gave rise to a big outbreak at your end and then spreading to the US. So the outbreak control then, I think the main thing was that we provided early MMR from 6 months of age in 29 municipalities with low coverage. And of course, there we had to balance risk of infection and suboptimal effectiveness. I get into that. Now, the recent increase in cases that you could see was not a Bible Belt outbreak yet. It was very scattered clusters of cases, quite a high number of cases, unusual for the Netherlands, especially we haven't seen so many since the 2013-14 outbreak, and even 1 fatal case, unfortunately. Now switching to rubella. So this is the time series for rubella, and you see it's much quieter. We've had a big outbreak, a Bible Belt outbreak in 2004, 2005, and a smaller outbreak during the measles outbreak, actually. I'll go into a little bit in that outbreak. It was, again, a measles outbreak, really Bible Belt outbreak of rubella. There was huge underreporting. We only had 387 notified cases, but there were these, consequences of rubella in pregnancy, and that was 14 infants with congenital infection and 11 of them with defects. And this is an example of the multiple defects that arise from rubella infection in the first trimester, which is really tragic, because it's completely preventable in principle. Now, that also spread to Canada. That happened in Ontario. So I worked a lot with Jeanette Macy and other Canadian colleagues to document what happened. Interestingly, there were no CRS cases in Canada, but there was also no follow-up after birth. So there may have been some infants with defects that appeared later. The thing we are worried about in the Netherlands, and that maybe is relevant for you also, is that we haven't seen rubella circulation since this outbreak. And that's now already 20 years. So we are getting into the age of, reproductive age, and with a lot of susceptibility probably in the unvaccinated communities. I get to that. So it's part of the interventions that I will move to after I've discussed research. In terms of research, we have a lot of areas where we are focusing our attention. I'll show a bit in more detail the ones I've highlighted red. The other ones I can discuss very briefly. So the phylogeny, and I've mentioned the names of colleagues, so through me you can easily get in touch. The phylogeny focuses mostly on the added value of near whole genome sequencing to identify transmission chains. Joyce is looking at the determinants of MMR vaccination, and her project now is to assess specifically the effects of the pandemic. Did it worsen the uptake in a continued way? I mean, during the pandemic, it was lower, the uptake, but is that something that is continuing after? We have sociologists working with us about acceptance of vaccination. We have quite a large project about wastewater surveillance of measles to see what is the added value. And and then I'll go into the topics that are highlighted in red. So the first one is a bit older, but it's just a really nice example where an outbreak can be used as a natural experiment to study the natural history and pathogenesis of measles. So the outbreak in the Netherlands was used to take samples and to study cellular immunity, and that led to important articles documenting how measles suppresses the immune system, and that is really an explanation why measles is so much more severe in developing countries, where of course there's much more risk of subsequent infections for children or people who have had measles. So I think the outbreak was an opportunity to make the most of it and take really samples from children on day -1 of infection, because we knew which children would get measles. Now, the other big thing is, of course, the research on early MMR. So that's this topic this intervention where you give MMR before the recommended age from 6 months onwards. And it's not optimal because there's interference of maternal antibodies and there's immunological maturity. But of course, in high-risk settings, it's already a recommendation to use it from 6 months of age to protect children. And I was involved in 2 years ago, technical consultation where especially the concern of immune blunting was discussed. It's really difficult to study it. It's not been clearly demonstrated, but you do see that children who've had this early MMR have faster waning. So we have done 2 big systematic reviews published in the Lancet Infectious Diseases. So that's already older work. We did an update to actually look at MMR even below 6 months of age, because if you recall the waning of maternal antibodies in vaccinated mothers, children are already susceptible from 3 months of age. So maybe we should give it already before 6 months. But then, there's insufficient data. There was insufficient data to recommend it under 6 months of age. And we are now updating the big review also based on work that we presented for WHO in 2023, and that's work in progress. So there has been work at RIVM to study the uptake of the early MMR. So this is during the outbreak in 2013-14. So I'll put them all up. I think the key message here is that the uptake was reasonable in children who had also had previous DTP. So these are children of vaccinating families. But the uptake of early MMR was, of course, very low in families that declined vaccination. So they also declined the additional offer during the outbreak. And Laura McLaughlin, who worked with us then, was able to study risk factors for declining. And at regional level, it was a high proportion of votes for the Orthodox Reformed political party, also unknown country of birth of parents, and high socioeconomic status compared to very high. So my take on this is that those at highest risk did not accept it. And maybe the worried well people who were not actually exposed did accept it. So I think this means it's really a challenge for public health. So we have to define a population that is really at risk with high sensitivity and specificity, and then communicate the risks and benefits. So we don't want to reach the worried well because they only have the disadvantages of less well immunity, whereas they don't actually need it. So it's a tricky a tricky thing, this intervention. At RVM, we also have these immunogenicity studies of the early MMR. They were set up already in that outbreak of 2013-14. And we now have results, I'll show them in this graph, that you do actually see a faster decline in children that received the early MMR 0 dose. So we now have follow-up for several years, up to 6 years, and you see that the early vaccinated children actually drop below the level of protection. So yeah, is this an academic concern or is this a real concern? I guess it all depends on how many children you vaccinate. And if you, it's a no-brainer that if a child is or a family is really at risk of measles because it's in this community, then of course you want to protect the child now rather than being concerned about some waning immunity later. But yeah, if they're not really at risk, you shouldn't give it. You should stick to the routine age. So that's the challenge, I think. Now, moving from early MMR to mathematical modeling. So there's been a lot of work in the Netherlands also because we have so good data on seroprevalence, on registers. We can actually model the outbreaks quite well. So we've worked with James Monday on this study. And we have detailed data on households and school attendance. And he applied this measles transmission model and was actually able to show that the linking between primary and secondary schools in terms of children from the same households is very strong for Orthodox Reformed and a bit less so for anthroposophic. So yeah, it's sort of obvious, but it means that children in the same household who attend primary and secondary school both choose Orthodox Reformed schools, and this is much less so for Catholic and general schools. So, and this actually explains the interval between our big outbreaks, because the next outbreak can only really occur when you have susceptible children in the same household that attend primary and secondary school. So that means that you need at least 12 years after the previous outbreak to have enough susceptibles, even in secondary schools, to support this big nationwide Bible Belt outbreak. And so our next outbreak is actually based on all of this modeling work expected next year, not yet this year. Now, to me, this whole thing is somewhat frustrating sometimes because we know exactly what's happening. We know we can put in our calendar May 2026, next big Bible Belt outbreak, but what can we actually do about it? So I think there, Helma Ruijs, a colleague here at RVM, has done really a lot of work with the Orthodox Reformed community. And we have this current priority of rubella. Other people are, of course, working in low coverage pockets in large cities now, based also on the results that we have from the determinant study. And I think we really need to prioritize where do we need to focus our efforts. And I'll talk a bit more about the Orthodox Reformed work that mainly Helma Ruijs worked on for her PhD. So I think the big innovation there was that she worked with the National Patient Society, Dutch Patient Society, which is actually a group, an NGO of Christian denomination. And the innovation was that the discussion about vaccination was done from a religious discourse. So that means that you use terms that mean something in religious terms, so divine providence, trust, responsibility, to open the conversation. So you don't start with your public health terms of burden of disease, severity, illness, hospitalization, but you start with themes that mean something in the religious perspective. And recently I also found this from an anthroposophical GP in the Netherlands. So this is a text from the invitation for influenza vaccination. And that GP also used anthroposophic themes in the arguments for not getting vaccinated. So the anthroposophical discourse is that illness and influenza can be a moment of rest, reflection, reordering, and that after recovering from such an illness, you may feel refreshed and ready for a new start. I think many people can actually relate to that. And this is more the anthroposophical approach to illness and reasons for not wanting to prevent it. But of course, I think here the GP got the balance right, because the actual risks were also well brought across in that invitation letter. Now, the current priority in the Netherlands is, as I mentioned, that we are worried that currently in our Orthodox Reformed community, women of childbearing age are less well protected against rubella than their mothers, because we've had now quite a long inter-epidemic interval, and we've had much less natural immunity building up in that. And probably women in this community are not aware of it. They might think, well, I'm not vaccinated, but they don't realize they are at much higher risk because of this longer interval. So we are busy doing a risk assessment, and we think that indeed the susceptible ages are not, there's now a broader age band where women are susceptible. We do realize that the global epidemiology of rubella has changed, so there's probably a reduced chance of introduction. But we do think that we have a responsibility and a duty of care to at least inform women in these communities that they are at an increased risk of being susceptible. And I think we need an active outreach to at least offer vaccination. So this is very topical. We have a meeting to discuss that at RVM in October. And to be honest, I think it's also probably relevant for Ontario, where, as far as I know, you haven't had big rubella outbreaks since the one imported from the Netherlands, but I may be wrong about it. So yeah, I think you really need good data to be able to do a proper risk assessment. That's the bottom line for that. And in the Netherlands, we're fortunate that we have this vaccine register nationwide. So it's actually easy to target, at least by sending a regular postal invitation for vaccination through this register. Now, I think that was quite a tour through all these different topics that we are working on with measles and rubella in the Netherlands. I'm glad we have some time for discussion, but I first go through the summary and synthesis of it all. So I think the key thing is that we've been lucky with very high uptake for years of both measles and rubella, a very high uptake, but we've had this clustering in socio-demographic and geographically clustered groups. And that clustering, the heterogeneous vaccine uptake, actually leads to very large outbreaks that are in theory preventable. And that's due to our shared history of migration from the Netherlands to Canada, has had very international implications for both nations. Now, I think we are fortunate that we have very good data in the Netherlands, these voting proportions, we have nationwide registers, we have sero-epidemiology surveillance where we collect reasons for non-vaccination. We have quite a large mathematical modeling team within RIVM, and we have a reference laboratory both in RIVM and Erasmus with a fair number of people working on measles and rubella. So we are very fortunate that we have a lot of insight into all of these angles of the situation to explain what we are seeing. Yeah, it's slightly frustrating that the opportunities for prevention are still limited. But the key thing I think that has been developed is that, and it's not easy to do that from within public health, to take a religious discourse. I think you need to work with other groups to be able to do that. Regarding the early MMR, I think it's all about targeting exactly those at risk and trying to prevent the worried world from wanting it. And I hope for rubella that we are now able to actually prevent CRS once this next Bible Belt outbreak would occur. the situation has given plenty of opportunity for research, and I see that as an upside of the whole situation. At least we've made the most of it to expand our knowledge and to share that, and that really has international relevance also to underline the importance of vaccination, for example. That case was made very strongly with showing how severely measles can suppress immunity for a long time after the infection. And that's more reason that we have this discussions about how to communicate our findings and how can we avoid stigmatization whilst at the same time be very clear in what we see epidemiologically and how we target our communication. And I think this moral debate has been very interesting experience. It was for me the first time actually to have this systematic approach. And I think it's a challenge for epidemiologists that we should study networks. We should have better proxies than the more simple proxies of country of origin and maybe religious denomination. Yeah, that's where I wanted to end, after acknowledging, of course, all the colleagues in the municipal health services and a lot of colleagues at RIVM and at Erasmus Medical Center in Rotterdam. And I want to thank you for tuning in and listening to this presentation. So I hand over to Sarah, I think, at this stage.
That's right. Well, let me say a very sincere thank you to you, Dr. Hahné, for that incredible presentation. I was noting all of the parallels and the connections to many of the challenges that we have experienced in relation to this most recent measles outbreak. And I'm aware that we have many colleagues from other parts of Canada joining today's Zoom call today. And so I think your synthesis slide actually wrapped up so many of those really nicely. I'm also really pleased that we have, I think, a fairly good portion of time to now interact with you and pose questions. Yeah. So there are just there's a handful of questions in the chat, or the Q&A pod, I should call it, but I'd really encourage everyone on the line to pose questions so that we can benefit from our brief time here with Dr. Susan Hahné. So I'll go to one of the first questions here, and so I'll read it out loud. I think it speaks for itself. So it's saying, in communities with low MMR vaccine uptake, in your experience with these previous outbreaks you've been describing, how were the school outbreaks managed, given the anticipated large number of susceptible contacts in those schools? Were the schools closed for the incubation period, or were there alternative approaches taken? I think that's of particular interest in terms of outbreak response. Thanks.
Yeah. So schools have been very important for in these measles outbreak, also to make the spread across the entire community. And school closure was not something we actually did for measles. We did a theoretical paper, The Effect of School Closure on Measles Outbreaks. That's a paper with a colleague called Don Klinkenberg. And at the time, this was pre-COVID. And we thought, well, it'll be unlikely that ever schools will be closed for an infectious disease risk. We did not know what was coming, of course, with COVID, when schools were closed for a very long time in subsequent periods. But for measles, that as far as I know, never happened. There was a vaccination offer, of course, also through schools, but the uptake of that was very limited. Also vaccination offer through the municipal health services. But the uptake of that during outbreaks was very low. That's also in recent outbreaks in Islamic schools, the uptake of vaccination is very low. I think more recently, an actually more innovative approach has been to ask families with unvaccinated children, when there has been an index case in the family, to keep the other children from attending school, the other susceptible children. So that's quarantining them, not asking them not to attend school. And what I've heard through conversations with colleagues is that has been, the compliance with that was fairly good. And people understood that was something they could do to limit spread. And and I think, well, it's difficult to say how effective it is, but it seems that it worked fairly well. And the experience with the Orthodox Reformed is that they are really pro-public health. They are not marginalized, they're not backwards, they're really educated people. They're just specifically against vaccination for these religious arguments. And something like quarantining would not be, it's not in one of the catechisms, thou shalt not quarantine. The experience has been quite positive, I think, and also in the other communities, like Moroccan communities. So I think that's something that has been used more recently, but school closure has not been used in the Netherlands for measles.
Okay, great. Thanks, that's helpful. And that I think takes us nicely into another question that's been posed. So the participant is asking Dr. Hahné if you can speak a little bit more about best practices that could be used regarding incorporating, I think in one of your slides you referred to it as religious discourse. So what are the best practices in terms of incorporating those messages into health messaging? And who is the who's delivering that messaging? Is it clinicians? Is it public health? Is it religious leaders? There's a lot of interest on this.
Yeah, so I think from a National Public Health Institute, it would be difficult to do that. If we suddenly start to talk about, first, we do not know, we're not experts. And it would be too much mixing state and religion. I think that would be difficult to do it. So I think the good practice is to find an organization and to find, religious leaders, and maybe also practitioners with that background who are able to do it. And as a simple public health professional, you're probably not able to do it in a respectful and in a way that makes sense. So you need to find counterparts from the communities. And then I think the respectful way to do it is to not just find the religious arguments in favor, but also then share religious arguments against vaccination. I think that was also the innovative thing that Helma Ruijs, in working with this NGO in the Netherlands, did in her leaflets, that there were vicars explaining why you could interpret the Bible in favor of vaccination, and there were others explaining why it's really cannot be interpreted as supporting vaccination. So I think that's what is good practice, to show both sides and also to find people from the community to work with closely. And of course, you can work closely behind the scenes from public health with these NGOs or with these stakeholders. But I think if you go out in the public, you should take a step back probably with your public health messaging and have the more balanced discourse being led by people from that community. And I think then it might work well, but I haven't. So in the Netherlands, we see that there seems to be a general improvement in the uptake over generations, quite slowly, but we haven't done a systematic evaluation of how well these things have worked. It's just very difficult to evaluate it.
Okay, well, thanks for those reflections. I'm going to turn next to, I think, a really interesting both comment and question in the chat. It's someone who's providing their reflections in relation to the outbreak of measles in British Columbia that you included in your table. That was related to the 2014 Netherlands measles outbreak. And so the participants noting two observations from that experience. One is that in British Columbia, the impacted community took steps to isolate themselves to avoid transmission to others, others who outside of the Dutch Reformed community, and that there's also the note that when it was explained to them that measles vaccine is not 100% effective, which, as we all know, is certainly not the case, that there was the perception that was a factor associated with them being more likely to accept it. So just wondering, I think the question for you is, just to hear your reflections in response to those observations and whether you've heard anything similar in terms of communities within the Netherlands.
Yeah, so the geography and the density in the Netherlands is much different from Canada with our population. I didn't do the calculations, but we're a very tiny country. So I have never heard of people or communities isolating themselves. And the spread is really through schools, and the only thing that is more recent is this quarantining of susceptible contacts. And I think, the isolation of cases, measles is so infectious even prior to the occurrence of symptoms. So I think, the damage has been done before people can isolate. And in the Netherlands, due to the density of population, I think the isolation would be difficult to do and not be effective. And this argument of the vaccine not being 100% effective, I haven't heard it being used as an argument in favor of vaccination. So it could be taken up. I know that I just look back to the information we collected in the Rubella outbreak, and actually the reasons for non-vaccination are very mixed. So it's not 100% pure religious arguments. It's also being scared of side effects. And just talking with Helma over lunch actually today, she mentioned to me that also now in COVID times, people of Orthodox Reformed communities also mentioned lack of trust in government and lack of trust in vaccines as an argument. So it's I think it's more work for us actually to keep ascertaining what are the real reasons underlying vaccine hesitancy, and not assume that it's a person of that background, it'll be a religious reason. There can be a mix of reasons, and some are more easy to address. I mean, lack of trust in government is particularly difficult to address, I think. But if it's scare of side effects, that's something we can give good information about.
Yeah. Thank you. So I'm going to turn us to our next question here. And the question is asking for you to reflect on these previous outbreaks that you've described and whether, I'll paraphrase it, it's essentially, has the outbreak ended because there's been successful implementation of various control measures, or has the outbreak ended because it's essentially moved through all of the susceptible individuals?
Yeah, really the latter, because in this outbreak control, the uptake of vaccination has been very limited, and measles moves too fast, really. You would need, outbreak control through vaccination is, you could try to do it. In our Bible Belt, it does move geographically somewhat slowly. I mean, not it takes a few weeks, but the uptake is just very low in outbreak vaccination. And in our seroprevalence studies, for example, in the Rubella outbreak, we could see that the attack rate was very high. The seroprevalence in unvaccinated people is nearly 100% if they were born at the time of or if they have experienced the outbreak. So it's really natural immunity that stops the outbreak.
Yeah. Thanks for that. So I'm going to take us to a question that's actually asking about some of the data caveats I think you provided in relation to that coverage graph, looking at the declines post-COVID. And you made a comment about the changes in the consent procedures related to data getting into your registry. And so the question is asking for a little bit more details on who or which organization is actually obtaining that consent. Is it at the individual interface between a client and an immunizer, or is it at a different organizational level? And if you could sort of walk us through what does that actually look like in terms of implementing a consent procedure?
Yeah, so it is between the actual immunizer and the client.
Okay.
So it's at that level. And it's an opt-in at the moment, so they really have to give consent for the information. So the information is registered locally at the clinic, because it's a medical file of the individual client. So it's always registered, the act of vaccination. But the question of consent is asked whether it can be transferred to our national register. And that's now since 2022, I think, that it's being implemented. And estimates are that around, it's very difficult because we do get numbers of anonymous vaccinations, but we don't get that split by which vaccine and which age group. So it's impossible to adjust for the anonymous vaccinations, but it's only a few percent. So we think we underestimate coverage by, I don't know it by heart now, but maybe 4% or so, which is important, but it's not 15% or so. So the decline is a true decline that we see. And for us, it's really making our work very difficult, this informed consent. It's you just do not have good information on and it actually, in COVID times, we showed that it actually can have quite large effects on vaccine effectiveness estimates and of course on coverage estimates. So we're working hard to make it an opt-out procedure, so that the standard is that it gets transferred. But that's still somewhere in the, we say, in The Hague, so then the government regions where it has to be implemented in a change in the law. But it's, I think it's for us, well, we have been blessed with a complete register for years, and it was a bit of a shock to our system that suddenly we had incomplete data and this informed consent. So, it happens at the interface between the immunizer and the client.
Okay, well, thanks for clarifying that. I think there's interest because, of course, in Ontario, we don't have a fully comprehensive registry. So it's interesting to learn about jurisdictions that do and how they work, and I guess that some of the challenges.
Yeah.
So in your presentation, we'll go to another question here. In your presentation, one of the earlier slides, you noted that the timing of the second dose of MMR was pretty recently moved. I think it was originally at 9 or 10 and moved to age 3. And so I wonder if you could tell us what were the factors associated with moving up the timing of the second dose, and if you could also comment on why age 3 was selected. And I'll give you, there's some context here. In Canada, some provinces give the second dose at 18 months. Some provinces give it at age 4 to 6. So I think it would be interesting to learn why you chose age 3 versus perhaps giving it in sort of a toddler age range. But more generally, if you could speak about what was it that prompted the moving up the timing of that second dose?
Yeah, so these decisions are made by the Health Council. They have a very large work agenda, so it's not that they can assess that type of schedule changes all the time. So it took a while for them to start considering that. I think in the past, people thought that maybe the second dose was important for rubella to have it not too soon, to make sure that you have adequate rubella protection at childbearing age. But I think that's a misunderstanding, because a single dose of rubella gives lifelong protection. So it doesn't matter what you do with your second dose. For mumps, we were also a bit concerned because we had mumps outbreaks in students. So we thought that maybe a bit later, having the second dose for mumps would protect people better in student age. But actually, these student outbreaks have stopped and we haven't had problems. So I think that evidence also helped giving courage to the decision to bring it forward. But your exact question of why 18 months or why it was 3 years, to be honest, I do not know. I don't know what was exactly the modeling or the decision. Maybe it was also a scheduled decision to look at all the other vaccines.
Yeah.
So there's probably a Health Council recommendation for this change. They do have reports in English, so it's probably findable. If somebody wants to get in touch with me, I can look with them together to find it in those reports.
That's great.
They've been pragmatic decision.
Yes. Yeah.
Yeah.
Yeah. And pragmatism is important in complex immunization schedules. All right. Well, Dr. Hahné, I'm looking at the time. It's now 12 noon, and so I think that takes us to the end of our time with you. But I want to conclude with a very sincere thanks from all of us at Public Health Ontario, but also all of our colleagues across Canada who've joined the Zoom webinar today to listen to your talk. And thank you so much as well for the opportunity for the interactive discussion. I think there's so many parallels between these outbreaks
Yeah,
and what we're experiencing now, and unfortunately, what I think we are anticipating we may soon continue to experience with more regularity. And just wanted to commend you and your group also for the incredible research outputs that have arisen from these outbreaks. I think they've really greatly contributed to our knowledge and understanding. And so just wanted to conclude with a sincere note of thanks. And I hope we'll have an opportunity to continue in some follow-up discussions, given that I think Canada, as you've noted, our sort of upcoming future, I think will involve more collaborations with international collaborators regarding BPD control.
yeah. I look forward to that. I think we should continue our discussion and
Excellent.
conversation. Yeah, thanks for the opportunity.
Okay, great. And then for our participants, you will shortly be receiving an online survey. We receive feedback from our participants to improve our programming. So please do look for that online survey and share your feedback with us. And with that all being said, I'll wish everyone a really wonderful rest of your day. And to Dr. Hahné, I know it's evening in the
Yeah,
Netherlands, so thank you for a very long work day and fitting us in into, I'm sure, a very busy schedule. So goodbye, everyone. Thank you so much.
thanks a lot. Bye bye.
Bye bye.